Welcome you all. My name is Dr. PJ Madam Rafi. Today we are going to discuss about bone mineral homeostasis. That means hormonal which are affecting on bone mineral homeostasis and non-hormonals and drugs which are affecting bone mineral homeostasis. Okay. So first is hormonal regulators of bone mineral homeostasis. In that hormonals will have parathyroid hormone, vitamin D hormone, calcitonin hormone, fibroblast growth factor 23 hormone. There are three major organs which will involve in maintaining of bone mineral homeostasis, that is bone, kidney, intestine. First of all, we will see each hormone one by one. First, parathyroid hormone. When body will expose hypocalcemia, it activates parathyroid hormone, which increase bone resorption by stimulating osteoclast in bone matrix. That means osteoclast will get activated. It will release calcium into the blood circulation. When parathyroid hormone, it will also enhance reabsorption of calcium from the kidneys. At the same time, it is reabsorb calcium and will allow to lose potassium. Next one is parathyroid hormone and kidney promote calcitriol, that is 125 dihydroxy vitamin D3. It is an active form which absorb more calcium from the intestine. Okay. So if you see here, all those things will helpful in increasing of calcium level. First thing is it is loosening, it is activating osteoclast by enhancing, thereby it will release more calcium to circulation. Second one is from kidney, it was inhibiting loosening of calcium. Third one is from intestine, it is absorbing more calcium. So net result will be increased serum calcium, decreased serum phosphate. Why? Because serum phosphate, because it is allowing loosening of calcium phosphate from the kidneys. Okay. So thereby parathyroid hormone will increase serum calcium in the body and decrease potassium level in the body. Next hormone will be calcitonin. Calcitonin is when body will have hypercalcemia, it will causes releasing of calcitonin hormone which decrease calcium levels in the body by inhibiting osteoclast. Parathyroid hormone will activate osteoclast. Calcitonin will inhibit osteoclast. Okay. But by stimulating osteoblast, thereby there will be more deposition of calcium, extra calcium in the body. It will get deposited in the osteoblast, thereby body calcium level get decreased. So this calcitonin also increases renal excretion of calcium because calcitonin will be released in the body when it is have hypercalcemia. So it has to be controlled extra calcium by deposit into the bone. Say first one. Second one is by excreting out of the body. Okay, that is calcitonin mechanism. Next one is vitamin D mechanism. Vitamin D, they will have two types, vitamin D3 and D2. D3 is known as cholecalciferol. It is produced from the skin. Vitamin D2 is known as ergocalciferol. It is a vegetable source. Actions of vitamin D3 is the active form of vitamin D3 is known as calcitriol. It will act on intestine and stimulate calcium and phosphate absorption. That means it will enhance calcium and phosphate absorption from the intestinal part and allowing parathyroid hormone and calcitriol induce rank L ligand. This L ligand will be located in osteoblast, where this is a recently developed molecules also there. So this is recent technique present on osteoblast and increase osteoblast mediated activation of osteoclast. Okay, that means when this is also helpful in, it is one of the type of molecule which will be useful in osteoporosis treatment. Okay, that we will see in when you are dealing with rank ligand. Okay. So here vitamin D3, it will enhance serum calcium and phosphate by increasing nutritional absorption. Next one is fibroblast growth factor 23. It is produced from the osteoblast and osteocytes. It will inhibit synthesis of calcitriol, thereby decrease calcium and phosphate absorption from intestine as well as increase phosphate excretion from kidney. Okay, it will, first thing is decrease calcium phosphate absorption from the intestine and it will enhance, will increase phosphate excretion through kidney. Main result is, net result will be, it will keep serum phosphate low and it will maintain body sodium level, sorry, body calcium level in the normal homeostasis level. By how means? By excreting phosphate and by decreasing absorption of calcium. Okay. So those are hormonal parts. Now coming to the non-hormonal parts and drug part. Okay, in this drug non-hormonal and drug part, mainly bisphosphonate drugs are mainly helpful in controlling of bone homeostasis. Okay, so bisphosphonates are synthetic pyrophosphate derivatives. They mainly used in treatment of osteoporosis, mainly postmenopausal osteoporosis. Okay, their mechanism of action is inhibitory effect on osteoclast mediated bone resorption. That means osteoclast mediated bone resorption, one thing is inhibited. Second thing is accelerated apoptosis of osteoclast, because osteoclast will be apoptosis, obviously there will be no resorption will be there. Second one. Third one is suppress differentiation of osteoclast. That means immature osteoclast to the mature osteoclast by inhibiting interleukin 6. Their main action is in osteoclast only. One thing is because osteoclast will cause bone resorption. So by once if you are inhibiting or when you are destroying osteoclast, there will be no bone resorption. Okay. So that's how bisphosphonates will act. What are the groups drugs in the bisphosphonate will have? They have three generations: first, second, third. In the first generation we have etidronate, medronate, clodronate. Second generation is very important. Alendronate, pamidronate. Here most commonly we will use pamidronate drug. Next, third generation we have risdronate, zolendronate. In the third generation, zolendronate group drug will be most commonly useful, because these are mainly they will acting on osteoclast only. Okay. Next, therapeutic uses of this bisphosphonate is mainly postmenopausal osteoporosis, steroid-induced osteoporosis, Paget disease, hypercalcemia of malignancy, other malignancy conditions, and CML. This one also leukemia. Okay, in all these conditions, this they will be useful. Next group will be selective estrogen receptor modulators. Okay, these drugs will inhibit bone resorption by directly inhibiting osteoclast. Okay, this is also acting on osteoclast. How means it increases anti-resorptive factors. Anti-resorptive factors, those are IGF-1 and TGF beta. Okay, by increasing anti-resorption and by suppressing pro-resorptive factor, that is interleukin 1, interleukin 6, TNF alpha factors. There will be by two mechanisms. One is increasing anti-resorption. Okay, so anti-resorption of once they are inhibiting anti-resorption and suppressing pro-resorptive factors. Therefore, obviously there will be no losing of calcium into the circulation. Okay, so that's why these are bone resorptive factors. Selective estrogen receptor module, they will acting on bone and they inhibit the bone resorption. Examples will be relaxifene, bezodoxifene. These are very important drugs. They are mainly used in main purposes for osteoporosis only. Okay. Next group is calcium mimetic drugs. Okay, calcium mimetic drug will have cinacalcet. These are calcium sensing receptor present on the parathyroid gland that regulate the secretion of parathyroid. Why? Because parathyroid, when body have hypocalcemia, it will get activated, causes rising of calcium. Okay, so calcium activated these receptors and obviously decrease parathyroid hormone secretion, because when hypocalcium will be there, more calcium will be released. Obviously this will be get suppress the parathyroid hormone activation. So cinacalcet will act as calcium mimetic drug by activating calcium sensing receptors and parathyroid gland. So obviously, so these drugs will acting on the calcium sensing receptor, thereby they won't allow the elevation of calcium level into the circulation. Thereby there will be no bone loosening of or no osteoclast activity will get suppressed. Okay, there they will act in another mechanism by suppressing parathyroid hormone. Next one is strontium granulate. This is granulic acid salt of strontium. Inhibit resorption by blocking differentiation of osteoclast and promote apoptosis of osteoclast. These are all drugs will acting on osteoclast only. Thereby they enhance bone formation. Okay, they enhance bone mineral density. By how means? By blocking osteoclast and promote apoptosis of osteoclast. Okay, because osteoclast is the only drug where osteoclast is the only bone where it will resorb, means they will lose calcium to circulation. Osteoblast will get deposits, means they will take calcium into the bone. Osteoclast cells, they will lose calcium from the bone into the circulation. Okay, that's why most drug will acting on osteoclast only. Next group is denosumab. Denosumab is the monoclonal antibody. Here main thing is they will acting on rank receptors. This rank receptor mainly located on osteoclast. Okay, how they activate means rank ligand is different, rank receptor is different. Rank ligand is produced from the osteoblast. Okay, when body will have hypocalcemia, this rank ligand will get activated. It will come and bind on rank receptor. Okay, so when this receptor is located on osteoclast, thereby obviously osteoclast will get activated. It will lose blown calcium into the circulation. Okay, that's why here this denosumab monoclonal antibody, it is inhibiting rank ligand binding with rank receptor. Thereby no activation of osteoclast, so there will be no bone resorption will be there. Okay, that's how it will act. So this is all the mechanism it will helpful in maintaining a bone homeostasis. That's all. Thank you.